I would like to invite Dr. Nirmal Surya sir. Dr. Nirmal Surya sir is the President-elect of Indian Stroke Association and Chairman of Surya Neurocenter, Mumbai, founder, trustee, and Chairman of Epilepsy Foundation of India. He is also a consultant neurologist of Bombay Hospital and Medical Research Center, founder and President of Indian Federation of Neurorehabilitation. He will be talking about stroke care in India and way forward. Over to you, sir.
Thank you very much. Thank you, Pradeep, for the invitation to be here. So thank you, Kaho. I saw your movie, which was quite interesting and wonderful. Thank you for that. And it shows that how good you have been able to do the work. And I'm extremely happy to be part of this session on clinical excellence in stroke management. And Pradeep has already given a very brief about how the things are in India. And I'm going to take it a little bit forward. There may be some of the slide which may be overlap initially, but as he has already mentioned to you that stroke is the leading cause of death, not only death, but disability. And it also causes a lot of morbidity and mortality, not only in India, but a lot of developing country. He has also mentioned about the rural and urban divide. Obviously, stroke is much more common in urban population for the reasons we are aware. And now that we have got options of recanalization, both in the form of thrombolysis and thrombectomy, so time become a very, very important factor, 4.5 hours for thrombolysis to 24 hours for thrombectomy. Now, if you look at the pathway and what should be the stroke care program, and this is what exactly we need to do. We have to have basic of stroke and organization of stroke units. We should have an hyperacute, acute surgical management and secondary prevention system. We also need to have stroke system of care and surveillance. We need to have a solid backup of rehabilitation with PT, OT, SLP, cognitive, and others. And then finally, customization of stroke training for the local setting, SOPs, and assessment certification has been suggested by Dr. Jairaj Pandian. So if we look at the stroke care, it starts from pre-hospital care to the emergency department, to the neuroimaging, recanalization therapy, stroke unit care, rehabilitation, and follow-up. So these are the ways we can improve the stroke care in this country. And there are different setup, and you can see that each and every point is equally important for this. But lastly, not to miss early involvement of career, home rehabilitation, tele-rehabilitation, which is going to be crucial in the future. This is the stroke care team, and everybody is important. They have a role divided, decided, and at a time. Now, if we look at what are the current strategy, so there is a stroke care, acute. We manage the risk factor, hypertension, diabetes, alcohol, smoking, hyperlipidemia. We have reperfusion therapy by either the intra-arterial thrombolysis or intravenous thrombolysis. We have rehabilitation, which is physical therapy, occupation therapy, speech and neurorehabilitation. Then we have cognitive decline. We have to have drug development, robotic, cortical stimulation, stem cell therapies, and finally neuroprotection and repair through the anti-excitability, anti-inflammatory, anti-apoptosis. So you need to promote the repair, you need to have good neuroplasticity, and finally the recovery of the nerves for the stroke. Pradeep has already mentioned to you, and Southeast Asia, we have the burden, which is over 40% of global mortality of stroke. And among stroke survivors in this region, 1/3 experience severe disability, while the rest faces a high risk of stroke recurrence. And this was an article from Jairaj Pandian. I'm not going to go into the detail, but it's clearly mentioned about the Southeast Asia region, which is a important region. India is part of it, and hypertension, diabetes, tobacco, alcohol, physical inactivity, high ambient pollution, heat and humidity. They formed a important risk factor. And there are uncommon causes of stroke, which are like cerebral venous thrombosis, tuberculosis, infection, other infection, malaria, dengue, scorpio bite, snake bite, and dyslipidemia, which is another important. So we have a problem which is slightly different than other parts of the world, and therefore there's a gap between the availability of stroke care service and high incidence of stroke in Southeast Asia region. It also highlighted the shortage of both infrastructure and qualified personnel, and there are challenges which set against the backdrop of aging population, diverse geographical landscape, and socio-cultural differences hinder the uniform delivery of stroke care in the region. So acute care remains suboptimum. Post-stroke rehabilitation is significantly lacking. Rehab services remains fragmented, and the reintegration of individual into the community following a stroke faces a lot of challenges, and these really needs to be addressed. Another paper of surveillance of stroke, again from SEAR region by the Yogeshwar and his team, which again underlines the importance of stroke surveillance in tracking the burden and assessing progress in prevention and treatment. Though data we only available from 2 countries like India and Thailand, several challenges such as unreliable verbal autopsy, lack of data from rural area, comprehensive stroke surveillance, which all necessitate the high quality hospital and population level data. So we need a good data, and we need to have surveillance system, which is very, very important. So what are the point to remember? Given the most of the global stroke burden lies in LMIC, we need to innovate approach to target the modifiable risk factor, the stroke care effort to prevent modifiable risk factor, and again, acute stroke care need to be accessible, available through various health delivery mechanisms, and finally, implementation of digital health solution, mobile stroke unit, or emergency unit and telehealth to improve the stroke care. The post-stroke care and service with the long-term management, costs need to be major rehab, insurance need to be part of it to cover the rehabilitation, and again, comprehensive with involvement of people who need these services in decision making and planning the service structure. Also, non-communicable disease surveillance is vital, as many of these like tuberculosis and all other can cause the infection, cause the stroke, and integrated approach to stroke care will go far in saving and improving lives in the region. Stroke in India has been already mentioned by Pradeep, but 1 month case fatality varies from 18 to 42%. Mean age of stroke survival is 62.2 years, and 1/5 of patients with first ever stroke admitted to hospital are under 40 years of age, and which is a real serious situation, which has a devastating effect on the future health, finances, and welfare of individual and their family. So what are the barriers in stroke recanalization? We have window period for thrombolysis, 4.5 hours, and 24 hours for thrombectomy. The reason patient may not receive thrombolysis are included, and you could see that these are some of the delay, pre-hospital delay, in-hospital delay, and thrombolysis only few percentage of the patient. So delay in reaching the door to acute can be due to various reasons, patient and community level, pre-hospital level, as well as hospital level. And if you look at this data, how the patient come, is the patient come directly or the referred cases, and out of that, perception of stroke and recognition of brain as the affected organ. So there is a serious lack of communication and awareness of the stroke in community as well as in the referring physician. So patient arrived in window period directly is 21%, and by the referred pattern is also 24%. But what is important thing is reason for not giving thrombolysis, lack of awareness in physician is 42%, and that treatment gap and that awareness education can definitely be reduced by such symposiums and webinars so that people are more aware. Then there are patients are less aware of stroke. The symptoms in thrombotic strokes are slowly evolving in time, may lapse before the patient may consider it to be significant. Sensory deficits are less medically sought in the window period. Significant time may lapse before the patient living alone, reaching out to medical help while he suffered a stroke. And wake up and time indeterminate stroke further complicate the scenario. Economic status of the patient may contribute to the affordability of treatment. And these are some of the data and percentage which are important. Similarly, emergency medical system may miss subtle symptom. Presentation to non-stroke ready unit is about 13 to 71%. Lack of well-connected stroke network and limited transport availability in the longer distance. There also may be lack of imaging staff in the hospital, procedure delay, may miss to identify the stroke sometime, and lack of technical expert, which also are the barrier. So what is the way forward? We need to have a community solution. We need to have community and targeted population health education. A stroke-ready ambulance with in-house imaging can further reduce the delay. A comprehensive solution is establishing a hub and a spoke model, and the spoke hospital is thrombolysis ready, and the hub is thrombectomy ready. So in-house imaging, ambulance, and the training. So this is what is the hub, and these are the spoke. And you have the thrombectomy ready, you have physician, interventionist, intensivist, nurse, radiologist, and you have thrombolysis ready, stroke physician, nurse, and radiology. So this is something which can be done, an ambulance directly drip and ship. And you have a Tamil Nadu model like hub and spoke. So you have 28 hubs, 55 spokes with stroke ready center, and each thrombolysis center have a thrombectomy center, has thrombolysis center attached to them. And the Dr. Lakshmi has a script program. This is very useful. So you have Himachal teleneurology model. MB Padma and team has developed that. So they have done at CT scan facilities were roped in 18 such hospital. Workshops were conducted. They were taught reading plain CT scan. The blood sugar ECG were only other investigation done apart from the CT. TPA was made available in all those centers. All the 4 neurologists were made available on phone 24/7. And WhatsApp for transmitting CT scan for neurologists was done. And these hospitals were then designated as primary stroke center without any extra infrastructure requirement for any new manpower. The project was finally launched, and it's been going on well. And you could see that month-wise thrombolysis center at primary stroke center and you could see this is the CT scan sent on the WhatsApp. So these are the thrombolysis at IGMC Shimla, and this has been quite successful, and this paper was published by Padma and team at American Stroke Association. So a comprehensive solution is establish a hub and spoke model. Spoke hospital is thrombolysis ready, and the hub is thrombectomy ready. A few spoke centers shall cater to a hub depending on the area, population of coverage, and stroke prevalence. Model also involve the training of physician, radiologists, and nurses to be stroke ready, and mapping of the hub and spoke and its availability to EMS will result in prompt transfer of patient to the stroke ready hospital. In Mumbai, the KM hospital gives at a very low cost, and that again increases the number of thrombolysis because people know that it is the cost is less, they go there. There are quality indicator of intravenous thrombolysis from North India, again by the Jairaj Pandian and his team. And this shows that we need to work more hard, and only 20% patients were seen in window period, and of which only 4-5% were eligible for thrombolysis. So that's something which is need to improve. We need to do what we can do. So MBA get down to thinning the crowd at KM hospital was one way of creating an awareness. So we need to have proper insurance policy, green channel slip, and curriculum. So insurance scheme by the government can help bring the thrombolysis within the reach of low socioeconomic status patient, and KEM has done that. Stroke intervention has to be included as a part of neurology curriculum to equip the neurologist with the skill to perform thrombectomy. Involving stroke care in India require a comprehensive approach that addresses various aspects of prevention, treatment, and the rehabilitation. And I highlight few of the key areas which need to be focused on. Important is public awareness and education. Increase public awareness about the sign and symptom of stroke. Educate the population on importance of seeking immediate medical attention. Promote a healthy style to reduce the risk factors associated with stroke, such as hypertension, diabetes, and unhealthy diet. Prevention programs should have implement community-based prevention program targeting risk factor like smoking, high BP, and diabetes. Encourage regular health checkup for early detection and management of risk factor, and the foster partnership with NGOs and community leaders to reach to these diverse population. EMS should be strengthened and expand the emergency services to ensure timely transportation of stroke patient to nearest appropriate facility, and train paramedics and emergency responders to identify and manage stroke cases efficiently. Telemedicine and technology integration, leveraging telemedicine to provide timely consultation and support in the remote area, and implement of electronic health record to facilitate seamless communication among healthcare provider and improve continuity of the care. Specialized stroke units should be established in the hospital, equipped with specialized staff and resources for acute stroke care, and ensure the availability of essential facility like CT, MRI, and thrombolytic therapy. Healthcare professional training is very, very important, which should include MBBS doctor, MD doctors, nurses, paramedics, and the latest stroke management techniques. Promote the establishment of stroke care certification program for healthcare provider, and I'm sure Dr. Rana is going to speak more about this. Research and data collection, encourage and fund research on stroke epidemiology, treatment outcome, and rehab methods in Indian context, and National Stroke Registry. Though still there are regional stroke registry, we still don't have national stroke registry, and I'm sure Indian Stroke Association should take a lead to provide a national stroke registry, which can help to get the accurate data from all over the country. Rehabilitation services, not to forget, they have to be developed and enhanced for the stroke survivor, including PT, OT, and ST. Promote community-based rehab program to support the long-term recovery. Finally, patient and caregiver support. We need to provide information, resources for stroke patient and their family to cope with the physical, emotional, and financial challenges, and establish support group and network to facilitate knowledge sharing and emotional support. Government policies and funding is important. We need to do the advocacy so that stroke care is prioritized and their prevention is also given importance. Allocate sufficient funding for stroke research, infrastructure development, and healthcare training program. Collaboration with international organization is beneficial for global best practice and experiences in stroke care. Now, what is again very important is to have the stroke support groups, and the Stroke Support India is something which provide the hope to the people suffered from the stroke, and they have their own mission and they are doing wonderful work, and involving them in creating an awareness, sharing the stories of the patients who have successfully treated would be useful. And we have been doing various awareness program on the World Stroke Day, or also during the conferences, inviting the people with stroke and listening to their issues and prioritizing that how we can take their challenges to the best. So what are the solutions? We can have short-term solution and we can have the long-term solution. Short-term solution is free of cost medicine in public hospital, which many places been given, National Stroke Helpline and stroke map of stroke ready hospital. Long-term solution is improved stroke awareness, low-cost innovative telestroke, training physician in acute stroke, dedicated stroke space for the stroke patient in emergency, and easy to achieve is city-equipped mobile stroke unit in remote, difficult to access area, fellowship program in neurointervention, lifestyle modification for control of risk factor, emergency cadre in all district hospital, and universal medical insurance, which looks difficult to achieve, but if a will and effort is being made, I think it is not very difficult. So what is called for change? Much has been done, but when we look ahead at what remains, we see only a beginning has been made. So it is time to give the same priority to training of multidisciplinary stroke team and development of stroke unit as was given to the coronary care units and the management of myocardial infarction. So these are the key points which should be the essential component for acute stroke care, and we have already discussed about this. So in conclusion, Enhancing stroke care in India necessitates a multifaceted approach encompassing public awareness, preventing measures, streamlined emergency services, technological integration, specialized unit, continuous professional training, robust research, rehab services, and strong government support. By fostering collaboration, leveraging technology, prioritizing holistic patient care, India can pave the way forward towards a more resilient and effective stroke care system, ultimately reducing the burden of stroke and improving the quality of life for individual and community across the nation.